Just to make an introduction for you, my name is Dr. Rohit Vasan. I am the Chief of Neurosurgery at the James A. Haley Veterans Affairs Hospital. It's a privilege to take care of our nation's veterans. I'm also a professor of neurosurgery at the University of South Florida, where I train numerous resident surgeons on how to perform multiple procedures and do our best to stay cutting edge to offer the best 2024 or 25 or 26 has to offer, depending on where we are in time. One of the procedures I'm excited to offer my patients is the TOPS procedure. I do a lot of motion preservation surgery. It's a passion of mine. I do think there's a role for spine fusions, but far less limited than what was even taught to me in my training. I believe there's a lot of good to be garnered from trying to preserve motion as long as you can for patients, as long as it's a sensible thing that you're trying to achieve for them. So in that spirit, I tend to look at patients as how can I preserve the motion for them? And I only take it away if I absolutely have to. I try to do whatever I would do for my own family member to keep motion as an alternative. So the TOPS procedure allows us to expand our range of indications to which we can preserve motion. So many procedures in the past that would have required a spinal fusion, either short-term or a spinal fusion long-term, the TOPS procedure allows us to kind of bridge that gap by preventing the fusion in the short term and or preventing a situation where you might need one long term. So arresting that cascade of what many people fear with back surgery, which is, oh my gosh, I had a back surgery, I have to have another one and another one. I'm going to have multiple over my lifetime and I'm going to just be bolted together. This may offer you an opportunity to prevent that cascade if you have the right problems that we can fix. Okay, so that's the framework really for this discussion. Would you kindly advance the slide, Jeff? Thank you. That's just me operating, and that's the TOPS procedure that you can see there on the left. And that's what the device actually looks like. It's just it replaces a portion of the back of your spine that we remove. So we'll talk a little bit about what we're going to be removing and what we replace and why we do that, to where hopefully if you meet with a surgeon who can offer this procedure, you have a greater understanding when you encounter them. And if someone doesn't offer this procedure, you may just want to look at your films and ask yourselves if you might be a candidate for this, and you may not be getting offered it because someone's unaware of it or they're just not experienced in it. Next slide, please. So this is just a side view of your spine. You can imagine this is a person's skeleton. This is their lumbar spine. On this view, they're facing off towards the left side of the screen. And what I wanted to show you is just the basic anatomy of what's in the spine. So the long story short, those big blocks of bone that you see labeled L2, L3, L4, those are your bones. Those are your vertebral bodies that support your spine. They take the bulk of the load of the spine. In between them, you see that beige looking substance. That's the disc, the intervertebral disc. And that disc should be getting taller and taller and taller as you get closer to the foundation or the bottom of your spine. Okay. Behind that, you see those yellow things sticking out. Well, those are your nerves. Okay, those are your nerves. And behind them, you see the bones towards the back of the spine. Those are your joints that are shingled on each other. And finally, the spine is processed as the stuff sticking out of the very back that you can feel when you touch someone's back, okay, in the middle of their back. You can imagine those nerves are kind of between everything, aren't they? They're between the disc. They're between the back of the nerve. They're housed very intelligently in the middle of your spine to give them maximum protection. But you can imagine if that disc doesn't stay where it's supposed to, if it toothpastes out and hits the nerve, that can cause a lot of nerve pain. Or if those joints in the back, if they overgrow and get gnarled and kind of nasty and put down a bunch of arthritic substance, they can squish the nerve. So it really comes down to what's causing a person's pain. So those can both cause a lot of nerve pain for people. Similarly, if that disc is gone, it's the shock absorber between the two bones surrounding it. So if the disc wears away and squishes the nerve, well, what happened to that disc? Well, it's not there. So now your shock absorber is gone. So now your bone's grinding on your bone. So you get back pain from the front of your spine. If those joints overgrow in the back and they rub on each other, right, they get bigger and bigger, that can cause back pain from the back, right? So my point is the front of the spine can cause back pain by losing the disc and squishing the nerve. The back of the spine can cause back pain by overgrowing the joints, and then leg pain by squishing the nerve. So it really is important that your surgeon goes through your pictures with you to where you and your surgeon agree that the pain generator, the source of your pain, is either the front half of the spine causing your back and leg pain, or the back half of your spine causing your back and leg pain, or maybe both. Okay, so keep that framework in mind. Let's go to the next slide. All right, so let's take an object you're really familiar with. Again, this is the same idea. Imagine that spine we talked about a second ago with the front half and the back half. Think about your car. Same kind of idea, right? You have suspension in the front, you have suspension in the back, and you have the passengers that are really precious in the middle of the car. And the front suspension and the back suspension, you can have a problem with one or the other. So if you hear rattling out of the front right corner of your car, you're going to it's not going to make a lot of sense for the mechanic to be fiddling around with the back left corner of your car. If you hear rattling out of the back right corner of your car, it doesn't make sense to fiddle around with the front left corner of your car. And it's the same thing with the spine. Oftentimes people have failed back surgery, quote unquote, because the wrong part of the spine has been identified as the pain generator and the wrong part of the spine has been treated. Now, occasionally, of course, if you let that front suspension problem go on long enough, you're going to eventually have back suspension problems, right? Because one failure is going to lead to overstressing another component and vice versa. If you have a back suspension problem, it's going to cause a front suspension problem over time. And so it's important to stop, identify things very early on, figure out what's causing the pain, the discomfort in the spine or the car, and treat the right portion of the object you're trying to take care of, okay? So again, same analogy, because the nerves or the passengers are in the middle and they're the hostages in this car if something goes wrong. So front suspension is the disc and the vertebral bodies in this case. The back suspension is those joints that are shingled in this particular analogy. Okay. All right. Next slide, please. Okay, this is just another view showing what that looks like. So again, the vertebral bodies are those big blocks on the right here. The facet joints are those joints that you see on the left side of the screen here. And you can see that red stuff and the green. Well, that's the nerve. And you can see the nerve is sandwiched between the front of the spine and the back of the spine. So the nerve can get pinched by the disc sticking out. The nerve can get pinched by those joints getting bigger. And so again, it's really important to figure out what's causing the problem so you treat the right part of the spine, right? As opposed to just removing everything and fusing everything and hoping you got it. Our strategies have changed as spine surgeons from what we used to do, which is carpet bomb, fix everything and hope we get the target, versus tactical SEAL type strikes of find out what the target is, just hit that and get out of dodge before you hurt somebody. So the point of this slide is the nerve can be pinched from the front or the back of the spine. Next slide, please. All right, so now you know a lot about the spine and how things get pinched. There are multiple ways to get to the spine: the back of the spine, the side of the spine, the back side of the spine, the side, the front side, the front. So again, this is everything your surgeon has to consider before they determine what you might need. So you really need a surgeon who knows about all of these things to be able to offer an unbiased view as to what you might need. If someone only knows about one of these things, they're going to just look for that in every single patient. But someone who does all of these things and motion preservation, they're going to have a very unbiased view and be able to treat you like a family member, which is more important. You have all the skills and all the weapons to choose from. You'll choose the right tool for the job. Next slide, please. So this is a CAT scan. Go back one, please. This is the CAT scan showing the back of the spine, those shingles I talked about, that back suspension. You can see how those things are shingled on top of each other. If those shingles happen to overgrow, you can imagine they'll squeeze into that hole where the nerves come out right in front of them, right? So this is a back suspension, a view of the back suspension. The next slide I'm going to show you is, if you can advance it, Jeff, is a very special scan that shows where inflammation or the source of inflammation is in your spine. Okay, so this is a picture and you see the spine just like you've been seeing it before. And I'm going to make everybody on this call basically a much smarter interpreter of the spine imaging. If you look at this, I want you to ask yourself, there's a big orange glowing spot there. Okay, is that in the front suspension of the spine or the back suspension of the spine? Well, it's in the front suspension of the spine. It's between the two vertebral bodies where the disc is. If this person has back pain and leg pain, it's probably because the disc is worn out. It's probably because a disc is sticking out. This isn't the kind of patient who's going to respond to tops. They're going to need something else, either an artificial disc in the front or a spine fusion from the front. And so, again, if I offered this person tops, they won't really do very well. All their pain would still be there, right? Next slide, please. Now, conversely, look at this picture. This is a picture that shows the back of the spine lighting up. It's that back suspension. It's that shingle, right? The disc looks healthy. On the left, you see a CAT scan, and where the shingle should have stuff in it to help cushion the movement of the bones. On the left, you see that black circled in blue. That's just air. There's nothing there. This is the back suspension wear out. On the right, you see that, again, specialized scan showing all the inflammation in those joints in the back, but the disc is spared. This is just a back suspension problem. These are the problems that you can fix by removing the back suspension and replacing it, right? Because if you have a back suspension problem, if I take out the back suspension, there is no problem, right? I have to replace it with something which historically we would fuse, but now this is where TOPS come in. TOPS comes in as a facet replacement, a back suspension replacement, okay? And so when I remove this person's back suspension, their bones are no longer grinding on each other. Their back pain is gone. Whatever's squishing the nerve is also gone. So this is a perfect candidate for a TOPS procedure rather than a spine fusion, which is what a lot of surgeons would offer this patient. Okay, next slide. So again, a perfect example of a TOPS patient is one where the disc on the left, the front suspension, this is the same patient, by the way, the MRI is on the left, the CAT scan is on the right. The MRI shows a nice, pretty healthy disc. They have some wear and tear, but oh my gosh, if this was my family member, I wouldn't fix those discs. They look pretty good overall. They look age appropriate for someone who's probably in their 70s or 60s or whatever, right? Their discs look healthy. You don't need to mess with those. But what you do see on the right is their facet joints have a bunch of air between them. If this person has back pain at that level, kind of above their belt line, above their hip, somewhere in that zone, it's coming from this aerated joint, which will light up on a scan. So this is a perfect TOPS candidate. You can also see there's a spike of bone above that air that's stabbing into the level above it. So you have the two bottom levels there where that air is. You see a big shard of bone there. That shard of bone is probably going to be stabbing the nerves, causing a problem. So when I remove the back suspension here, I'm going to free up the nerve. I'm going to remove all the stuff rubbing on itself, and the patient's going to feel a heck of a lot better without a spine fusion. Next slide, please. All right, so this is what it looks like. So if you look on the left, you see, I know your eyes are probably drawn to those screws and stuff, but look above them. You can see above them, you see two levels, and you see the shingles between the bones and that back suspension. And look where the screws and stuff are, the TOPS device. That back suspension is gone. I've completely removed it, right? So nothing's grinding on anything. The disc is tall, all those back shingles are removed, and the TOPS device has taken its place. It's centered in the spine on the right picture. It's well placed in the left picture. This person has a back suspension replacement. They're going to have no pressure on their nerves from the back. They're going to have no bone grinding from the back, and they're going to be a lot happier. And this person was a lot happier because of this. Next slide, please. Okay. A lot of people say, gosh, doctor, I was told I have a spondylolisthesis. Does this mean I can or can't have a TOPS? You can think of spondylolisthesis as the scenario I talked to you about, where if you let your back suspension have a problem long enough, eventually your front suspension is going to fail, just like your car, right? And just like anything else, I'm sure all of you have experienced some arthritic pain at some point. Your knee hurts. If your knee doesn't get better, you'll be walking kind of wonky for a while. And what's going to happen? Eventually your ankle is going to hurt, and then your hip is going to hurt because you're not walking right anymore, right? Everything else gets that compensatory stress and gets fatigued. The same thing happens here. You let the back suspension problem go on a long time. Well, eventually the front suspension is going to get tired of doing all the suspension load. And so you get a spondylolisthesis, which is a slip of one bone on top of the other. And here what I've shown you is a couple of different types of spondylolisthesis. In the left two pictures, the disc is stretched forward, but still maintains its integrity. In the middle picture, it's stretched forward, but still looks healthy. It's holding on. It's working hard, but it's holding on. On the right picture, well, gosh, that disc is tired. It was stretched forward. It's tried its best to hold things together, and eventually it just couldn't anymore. So now it's an unhealthy disc. The left two pictures are a back suspension problem with some front suspension fatigue, but still a healthy disc. You can do a TOPS on those guys, be okay. That patient will be fine. There's some laxity there and there's some slackening, but that can work out. On the right, you're probably not the wisest person if you do a TOPS on that patient. Now the disc that you're relying upon for motion in the front is no longer providing healthy physiologic normal motion. So these are spondies that don't get a TOPS, okay? But you can still see there are plenty of cases where a little bit of spondylolisthesis with a healthy front suspension can still get a TOPS procedure. Next slide, please. All right, so this is the kind of scenario where if everything is wrong, the front suspension and the back suspension, this is what we used to do, which is a spine fusion. Rods and screws from the back and those inner body cages between the bones in the front. There's still roles for these. There's still plenty of times to do these. I still do plenty of these a month when I run into problems that require the bolting together of bones. But oftentimes, you don't. This is for front suspension problems, situations where the discs are too far gone, there's too much compression, I'm revising prior surgeries and things of that nature. Next slide, please. But I always look at these, go ahead, Jeff. But I always look at the spine fusion as more of a last resort than a first resort. If I can find a way, if I think I can pull off a TOPS, if I think based on all my preoperative testing and the patient's exam and their level of mobility and their level of function, if I can get away with motion preservation with or without a TOPS, sometimes I'll just do a discectomy or something else as well. Those things, a little bit beyond the scope of this discussion, but there are other things you can do to preserve motion that don't require a TOPS. A TOPS just allows you to remove the maximal amount of bone and still preserve motion. So you can do motion preservation with no metal going in the body at all for certain instances. But these instances where someone told you, hey, you need a spine fusion, that's when you need to think about a TOPS, because at that point you can put metal in that'll let you preserve your motion. So I look at this as the first opportunity for people when they have to get metal. I try to do no metal and spine motion preservation first, then I go to metal and motion preservation, and then I go to metal and fusion if I absolutely have to. A lot of people treat that in reverse, and that's why we have so many patients out there who have spine fusions. And I'm not going to criticize other surgeons, but they may or may not necessarily have needed that out the gate. And as time folds forward, technology improves, so surgeons should be changing their practice to some degree to adopt technology that does promise better options for patients that may not have existed 5, 10, 15 years ago. Okay, next slide, please. And that's really what this is about. You know, it's hard to find a great surgeon who can help you. Somebody too young may have inexperience on their side, which may not be the most comforting thing. Somebody very gray haired may have a lot of experience, but they may not be adopting new technologies, right? And so you don't want, someone who just understands the new stuff and doesn't do anything old. You also don't want somebody who has a landline in their office and that's all they know how to use, right? At some point, technology gets better. None of you, I think, most of you are probably watching this on your smartphone. I don't think many of you would trade your smartphone for any of the other devices on here. At the time, they were all cutting edge. But time folds forward, and surgeons and patients, I admire all of you for taking initiative in your care to learn this stuff and be on in the evening on your free time. Surgeons should be doing the same thing. I pride myself on being able to offer the best thing for my patients in any given year. That doesn't mean I give into fads that don't work and nonsense, but I will try to find the best technology to help somebody. If I thought in my heart of hearts there was a pill I could give you to make all your back problems go away, I would put myself out of a job and prescribe that pill out of integrity. But that pill doesn't exist. So for right now, I'm going to pick and choose the best thing for you to have the motion that you were born with, that you should try to carry on as long as you can to prevent future problems from occurring. So it really does. It is in your best interest to look and see and see philosophically where your surgeon is. Are they just a decompression or a fusion guy, or do they do motion preservation in town? Do they do cervical decompressions and motion preservation and lumbar? Do they do TOPS? Do they do other things? And they offer you an unbiased representation of what is available to you, to where they can meet you at your goals, meet you where you are, and hopefully give you something that'll last years or even hopefully a lifetime without necessarily bolting your spine together. Thank you. I think I got one more slide there, and that's just because, well, I'm a red, white, and blue kind of dude. So there you go. I appreciate you guys. I think Jeff wanted to have a period of questions and whatnot. I'm happy to take anything, and I'm a very informal person, as you may have gathered. You can ask whatever you want.
Yeah, let's do that. So everyone on the webinar, you have a Q&A function on your screen. If you go into that Q&A, you can type in a question. And so we have some of those already. So I'll go ahead and read a few of those. And as we're reading them and you're answering them, Dr. Vasan, hopefully we'll have some more questions.
Sure.
First question that I have is, I have an artificial disc at L5S1 and have facet ablations 2 times per year for facet pain. Would I be a candidate for TOPS?
So some of it comes down to where are your facet ablations. If they're at the same level as your artificial disc, it's sort of a yes and a no scenario, right? If you're having facet failure at the level of your artificial disc, it may be an indication that you had a front suspension problem. They fixed it with an artificial disc, and now your back suspension is failing. TOPS is not indicated at present for 5-1. It sort of can be done, but the company line is that it shouldn't be done because of the way one is set up. It's at a higher risk of failure. And we don't know much yet about how tops and an artificial disc play together at the same level. So if you are having facet ablations and they're successful, that's awesome. If they ultimately stop being successful, honestly, you may require a spine fusion at that level, because we don't know how tops plays with an artificial disc, especially at 5'1", where you would almost need to bolt into something lower than 1 and make it all work in a hybrid situation. Some surgeons can do that. I would, if the right person came along and they understood that we are leaning towards the end of indications and into something a little bit more experimental, if they were absolutely understanding that this is not FDA on label use, but off label use, I would potentially offer that to somebody if the pictures made sense, the other levels of the spine were super healthy. We didn't want to go up there. If your facets are failing at a different level, yeah, absolutely. It may be you have a 5'1" artificial disc and a 4'5" tops or something else. That would be more conventional and probably readily accepted. So, if that helps.
Okay. Next question. I had a previous laminectomy. Does that mean my problem is coming from the back of my spine and therefore likely a TOPS candidate?
Great question. Laminectomies, if you've had a prior laminectomy, you've kind of got half of the tops done, right? It's a back suspension partial removal. A laminectomy is when you remove the middle of the spine, but not the joints. So think of that as we use the analogy of a car. A laminectomy is like making your car into a convertible, right? It's maybe a little bit less stiff, but the car's not falling apart, right? The back suspension hasn't been removed. A microdiscectomy is like opening the sunroof of your car. It's fine, right? The car's still stable. A laminectomy makes you still stable. Now, if they do a laminectomy and down the road someone says, oh my gosh, I got CAT scans and MRIs, the facets are blown, the back suspension is the source of my problem, then yeah, it may be worthwhile to consider a TOPS. It'll be harder because there's scarring there. It also depends how long ago your laminectomy was. It also depends what kind of pain you're having. Is your pain from having the spinal structures exposed, the muscles and tethering and being scarred down, or is it truly coming from your facets? So to make the discussion very sensible and easy to understand, I would say that your surgeon has to spend a lot of time ensuring that your pain is truly from those facet joints and not other things that can cause post-laminectomy pain. Then if it's from your joints, yes, it may be a reasonable thing to do a TOPS if your disc is healthy, if the scar can be navigated relatively easily, if the same surgeon who did your laminectomy is doing your TOPS because he knows what was in there last time and what he removed and what he tends to do in the past, it de-risks the procedure for you. Most TOPS procedures I do don't have anything done to the spine prior in terms of a laminectomy or things of that nature. That wouldn't exclude it from my mind if that was your pain generating and it all lined up properly, if that makes sense.
We have two questions here, and if you need, well, you can speak to your experience. If I need to help, I can jump in a little. But one
Sure.
is, are most insurances paying for this procedure? In a similar question, is TOPS covered by Medicare?
So I think that's a better question for you to take from a company standpoint because you know how that's referenced nationwide. I'm not sure where all the questions are actually coming from. There is a lot of hoop jumping that has to be done with private insurance and peer reviews and things of that nature. In the VA system, there's a little bit more equipoise. And that's going to be changing relatively soon. But at present, I can effectively do the best thing for my patients like they're my own family. I do have to defend my decisions oftentimes, but that's okay. I'm comfortable doing that. In the private sector, there's a lot more a peer review structure and things of that nature first before you can get onto insurance approvals oftentimes. Now, the company is very experienced in navigating those things. And once you get to the point where, yeah, this is something that you want to have done or it makes sense for you clinically, I believe they've offered a lot of assistance to surgeons to get those processes going, and patients as well. So I'll let Jeff
Yeah,
rest of that from.
yeah, that's right, Dr. Boston. So for private insurance carriers, things like Blue Cross Blue Shield, Aetna, Humana, just some of the ones that are across the country. We work directly with them. This is still considered an experimental device by a lot of those companies. Ironically, that you would think that when you have FDA approval and with the statistical um, superiority claim that we have overfusion with the device, you would think that that would mean something in the insurance world. It's very different, as you guys, I'm sure everyone on this meeting knows that. But we have success. So Dr. Vasan's correct. We have to work very intimately with your provider, your doctor. We have an entire department that does that. Sometimes this has to go to external review or an appeals process, and we have found success doing that. On the Medicare side, it is covered by Medicare. It does have a specific DRGs associated with the procedure. So it is covered by Medicare, and that typically goes very well. And we get authorized to do those procedures weekly. So that goes very well. There are two or three questions here, a little bit more specific to your area. One is, do you practice in any other hospitals in Tampa? Do you go to Winter Haven?
Yeah, sure, sure.
Uh,
Like I
yeah.
said, happy to answer any questions. So my main practice is as a federal employee. I work in the Veterans Affairs Hospital. I do. I'm actually I've been around a long time, and so I do help a lot of surgeons in the area when they need me. I take leave from my federal job and I go help a lot of folks. I'm privileged a lot of hospitals in the area. Most of my work I do is at Advent Health. I don't know if Tops is in that hospital yet. I know they were working on it. But I work very closely with a surgeon who I personally would trust with my own family, Dr. Travis Daly. He's at Advent Health Tampa. He sees all of the folks that I can't get to because I have a very limited private practice. And his integrity is beyond reproach. He's one of the finest human beings you'll ever meet. That's my endorsement of his character. And in addition to that, he happens to be one of the best surgeons you'll ever encounter as well. And so he sees a lot of my patients that are overflows from my old private practice. But that's where I tend to work the most is Advent Health Tampa. I can work at Advent Health Wesley Chapel as well. Oftentimes I have Dr. Daly see those patients and work them up. We talk about them together. I'm happy to come help with the surgeries and whatnot to make them smoother and faster for the patients. But, he's absolutely excellent. So I refer my community patients over to him for that. On the note of experimental procedures, I would also add the caveat that I certainly wouldn't offer anything that's experimental to my patients. My reputation and my patient outcomes are tantamount and paramount in my mind. So although insurance companies and whatnot can dub these things as such, I offer this really because it makes a lot of fundamental clinical sense. And the data across the pond where things have been done for decades is very, very compelling. So, I do think sometimes it takes a little while to play catch up. When you have FDA approvals, you have to play that sort of game or course in time. I think over time, people will realize that this is a very sensible thing to do. So.
It is a bit of a normal process for new technology. Insurance companies do take a while once they see some of the real world data and they see how many claims are coming their way for the potential procedures to be done. Eventually, they come around. It's just part of their initial phase of when you launch a new technology. It's just not recognized by these insurance companies. It's just the way it is in the U.S. And my comment was, as consumers, everyone on this meeting just should do your research, make sure you understand how your insurance company thinks about it. But it is interesting the disconnect between commercial carriers, insurance in the United States versus how the FDA views and approves technologies. There's a disconnect between that, and it's just the way medicine is practiced in the U.S.
Yeah, I would also add that a good thing about Dr. Daly, and like I said, I don't make money whether Dr. Daly does a surgery or not. And the good thing about the VA is all of us as surgeons there, we don't make money whether we do surgeries or not. I'm not a consultant for Premia. I don't make money from Premia. It's got nothing to do with that. I just try to do the right thing for people. Dr. Daly's the same kind of way. If you want to see a surgeon who can do all of these things, who does anterior disc replacement, posterior joint replacement, microdiscectomies, motion preservation, and can fuse you if you truly, truly need it, but isn't a doctor chasing the almighty dollar. If you want an honest opinion with absolute integrity, I would trust him with my children. And so that's who I would recommend that you see if you're in the Tampa Bay area. And I would say that even if you see him and he says I'm the biggest jerk in the world, I would still say he's the best in the private sector.
So we have time for one more question. We're running over a little bit here, and we've had a lot of questions here, and unfortunately, we don't have time to answer all of them.
I'm happy to
Um,
take a few more. No problem at all. I'm fine.
okay. Well, here's one that's just right in your sweet spot. So I have a grade 1 spondy at L4, L5, and some loss of disc height at that level. No back pain, but tingling in my feet when upright. Would TOPS be indicated to help stabilize the spine and hopefully help me with my tingling?
And I'm sorry, did that vignette suggest the patient had quite a bit of back pain or no back pain?
No back pain, just
Okay.
tingling in the feet.
Yeah, and so tops may be useful if it's the facet joints that are actually crushing your nerves. But to this person, I would say if you don't have back pain, right, at all, or just or very manageable back pain, if they get X-rays of you bending backwards and forwards, and your spine maintains normal harmony, right, bends within the confines that a human spine should, and assuming that your nerve pain is coming from structures that are more towards the middle of the spine, you may not need a TOPS at all. You may just be able to do a decompression on either side of the spine and connect the dots underneath the existing structures and get no metal whatsoever. So your big blowout procedure would be the TOPS, but you may be able to get away with something that's not even a TOPS, maybe no metal in your back. And so I would entertain and I would look at that. You certainly shouldn't get anything more than a TOPS, and you certainly shouldn't be getting fused if your spine's moving normally and you have no back pain. So to me, sounds like you may have a lot of options for what we would call an interlaminar decompression, where we go on either side, work at the midline, and leave all those support structures intact in the back of your spine, decompress everything around that, and you may be able to get away with absolutely no metal whatsoever in your spine, which would be a wonderful thing as well. Okay, so again, daily people like that would make those judgments very clearly without jumping down trying to do the most expensive thing for you. So
Another common theme here with a few questions is recovery time from TOPS versus recovery time from fusion.
sure. Depending on how, so that's a very broad question too. Like, how do you recover, right? And so, um, TOPS is, as a rule, a faster procedure than spine fusion, so it doesn't take as long. You're under anesthesia for less time. People respond to anesthesia differently. Some people, they can blow it out of their system in a couple of days. Some people can blow it out in a day. Some people take a few days to come back online. And the older you get, the longer stuff can linger, as you might know, right? So anesthesia recovery is conceivably faster because there's just less of it, less duration of it. You should be able to go home sooner. If you do a wide decompression like we do with TOPS, where you blow off all that bone in the back, your nerves are going to feel better. If your nerves were compressed in the zones that TOPS addresses, it's going to feel a heck of a lot better in terms of nerve discomfort initially. So the acute phase, you will feel better fast. You should actually have a lot of nerve decompression with fusion as well. But the problem is when we go to fuse you, we decompress your nerves like we do with the TOPS, but then we have to shove interbody cages between your nerves, and that can stress your nerves out and kind of cheese them off. And so that's why TOPS patients, as a rule, feel a little bit better than fusion patients out the gate. And then long term, we expect them to maintain that. So when we look at TOPS short term, we look at the decompression having a wonderful effect. The recovery is faster from anesthesia. The recovery is faster in terms of hospital stays, and they do go home sooner. Long term, I don't worry about your decompression. I only want the TOPS device to work to maintain your decompression. So long term, we're just surveilling you to make sure that device is still healthy and still doing its job, that hopefully it's doing right by you over years and years and years. The biggest thing for these procedures is making sure you're the right candidate for the procedure, to where you needed all that bone removed. Because if you needed that bone removed to get the TOPS, then that was stabbing your nerves. And once we remove that bone, your nerves are going to feel a heck of a lot better. It's going to be like removing a stick from your eye. It's going to feel a lot better initially. And like removing a stick from your eye, when you pull a stick out of somebody's eye, their eye is going to feel a hell of a lot better. But the vision may take a while. Parts of the vision may take a while to get better over time, right? So there's a immediate relief, and then there's a mid-range relief and a long-range relief. But in terms of immediate recovery from the procedure, it is quicker because we're just doing less stuff to you than we would be if we weren't doing a TOPS. But also conversely, like the gentleman or lady who may have asked me about the laminectomy, or when they had the slip but no back pain, not even doing a TOPS, just doing a decompression is going to be even faster in terms of recovery than a TOPS. So the less you do, one of the big goals, like my big goals as a surgeon, are number one, how can it be maximally effective with the least amount of surgical footprint in your body? If I can not touch anything I don't have to, that thing that I didn't touch doesn't have to recover. So you're going to feel better. But I also don't want to do sham surgery. I've got to do something meaningful and effective for you. So I always walk that line. So my big two are: be as minimally invasive but as maximally effective as I can be for your problem. And then make sure I set you up to where I'm not setting you up for a lifetime of repeat surgeries. One of the biggest things I can do for you as a surgeon is minimize the number of times you go under the knife. Ideally, the number of times you go under the knife is zero. But if I can't do that, if I have to help you with the knife, fine. I'm going to try to make it the fewest number of times you go under the knife over your lifetime as possible, because that's something I could do to make your quality of life better for decades to come.